بسم الله الرحمن الرحيم. Let us start our session with first presentation from Dr. Manal Rifaie, consultant radiologist at Teaching Hospital and Secretary General of Egyptian Society of Breast Imaging.
Bismillah ar-Rahman ar-Rahim. Thanks for the chairpersons. I'm really thankful that the introduction came from Dr. Hanan Guifel. She was my professor at the very start of my career. Then I need to thank Professor Dr. Tariq Dayastian, Dr. Muhammad Fawzi, and Dr. Nuran Hussein for the kind invitation for this prestigious conference. I am a Ministry of Health member, so this conference means a lot for me to be the first radiology conference on the Ministry of Health. So let's start with the title of the talk today. I need to highlight the breast imaging key skills our residents need to know. So we need a guideline to go through. This is what we are going to do in this lecture. First of all, we have to know that training is a pathway between the trainer and the trainee, where both should teach and learn the imaging key skills that follow the international guidelines. This is how we have to be minded with. So our goal today is to learn to educate yourself differently. And this symbol in the image, this was referred to as the key of life or the key of Nile in ancient Egypt. So we shall not change the door, but rather the key we use. So we are going to say some basics that we already know, but we have to make the main keys that you need to handle in your hand before going through your way. So the objectives is describe the key skills of breast imaging that educators should teach their staff. Besides, identify the main stations a trainee should go through. So today we are going to discuss 8 key skills. We are going to go one by one together. The first key is the screening protocol. This is mandatory for every radiologist to keep himself updated with the international guidelines regarding the screening protocol. The aim of the screening is early detection, and the mammography is still the main station for early detection or the screening in average risk women. And our target is to have a cancer treatment success and make a long survival period and add a good life quality for our patients. So how we go through, we usually start at the age of 40 and on an annual basis, and there is no time to stop unless discussed with the clinician based on the morbidity of the patient. So what are the risks of mammography screening? Omitting the rumors we hear, there are 3 main risks: the recall of the patient and the biopsy of lesions and the anxiety. Actually, you can adjust the recall and the biopsy through good education and well experience. So we can adjust the limit of recall and biopsy without affecting the incidence of detecting the cancer early. Then about the anxiety, this can be handled through communication. So what about high-risk women? Who are those group? Those are mainly people with genetic predisposition, first-degree relatives, people with history of chest mantle radiation, personal history of breast cancer, atypical lobular or ductal hyperplasia, and some add dense breasts in this category. So what are we going to do for those group? Actually, we will start doing mammogram at an early age, depending on each situation. And we will add another imaging modality, either MRI or ultrasound. So let's move to the second key skill. The second key skill that we should learn is quality inspection. Actually, I like this slide, and this diagram is used in industry. This is the key types of inspection. They usually do pre-production inspection and in-process inspection and final inspection. So how are we going to do this on our mammograms? We are going to go through 3 stations: determine, and the check, and the take action. So what is this? The determine is done when the patient enters the mammogram room. So we have to determine, are we going to do the standard views and make sure that your technician is following the rules? And there are some additional views can be added before we start. In case of large breast, we know that we are going to do the cleavage technique and imaging. This is the determine before we start. Then we will go for the check. This is at the time you receive the images in your PACS and the patient is still in the mammogram unit. So what are we going to do? We have to check the images, check the quality of the craniocaudal and mediolateral oblique views. And we have to know what items are we going to check. The pectoralis level, the inframammary fold, the projection of the nipple, to be adequate or inadequate. What's meant by adequate or inadequate? Means it is adequate for diagnosis or no. Inadequate, it will lead to improper diagnosis. So is this image adequate or inadequate? Actually, this one is inadequate. We cannot see the inframammary fold, and it is not the full length of the pectoralis muscle, and so the right nipple and left nipple are not in view. So what about this image? This image is adequate. It can lead to proper diagnosis. The level of pectoralis muscle is okay. Inframammary fold is seen. The right nipple is in view, but the left nipple is not in view, but it cannot affect the value of diagnosis at the end. So this one is adequate. So what else we do in the check while the patient is still there? We can add additional view depending on the requirements. That means we can add compression view if you have to need more clarification of the lesion. We can add magnification view if you want to make more characterization for the microcalcifications, for example. So this is done inside the room. By doing this check, we reduce the number of recalls that we can make to the patient. If we don't make this check on time, this means on the next day you view the images, you need those additional views, you recall the patient. It wastes time and brings an anxiety for the patient. So it's mandatory to do this check inside. So the next step, we have to take action. What's meant by taking action? This is at the time when the patient is finished the examination and you have to make the diagnosis. So you have to follow two ways. You have to make a meticulous inspection, beside follow a checklist so that you don't miss anything. So in this patient, one can be distracted by the presence of the implant, the glandular element. If you take a general view, you can say, oh, we just need an additional ultrasound to make more characterization. But by doing meticulous inspection and following the checklist, we can find this lesion. Okay? So the checklist we will pick from the lexicon which we'll discuss later. On ultrasound, it is the same. You have to follow the checklist also, but you have to make some techniques to obtain an optimal imaging technique. That means the patient position. I know when to make the patient supine and when to make the patient lateral. I have to choose the transducer frequency depending on the size of the breast. Then I have to adjust my depth and gain. And finally, to probably localize the lesions and measure the lesion. So this is the items which leads to good or proper quality of the image. All the quality inspection helps me for proper diagnosis. So what's next? The next is localization of the patient, of the lesion. So what's the importance of localization? Localization is important for the follow-up, or if the patient of the lesion needs a biopsy, or if there is a surgical resection planned. So you have to do it accurately. On mammogram, we have to mention all those items, the side, right or left, then to determine the quadrant, then to predict the clock face of the lesion, and then to measure the depth of the lesion and the distance from the nipple. For example, right breast, upper outer quadrant, 10 o'clock, anterior third, 3 centimeters from the nipple. This is how you're going to localize your lesion on the report. For example, on those images, I have the MLO and CC. First of all, I have to localize my lesion. I know the lesion, I detect it, then I localize the nipple, then I measure the lesion from the nipple. When I localize the nipple, I can say if it is in the upper outer quadrant, lower inner quadrant, I can assess. On the MLO, it is upper and lower quadrants. In the CC view, it is outer and inner quadrants. Then I have to assess the depth of the lesion. So I have to say if it is anterior or middle or posterior parts of the breast. Central, retroareolar, and the axillary tail are separate categories to have to be mentioned. Now, through using this nice diagram, we can predict the lesion location on ultrasound. That means if the patient is coming for mammogram, I detect a lesion, and I'm going to do the ultrasound of for the same lesion. I can, through this diagram, predict where to search, at which hour I can find this lesion, so that if I find 2 lesions, I know which one I can see on the mammogram. On the ultrasound, we usually use the clock face. So both are 12 o'clock on the right and the left, and both are 6 o'clock. 3 and 9 o'clock are different, right from left. So when I describe the lesion from the ultrasound perspective, I have to use the clock face technique. So what is the 4th key skill? It is breast imaging lexicon. Usually this key is usually discussed by all radiologists, but putting all keys in arrangement makes things go easy. So if you start with the lexicon without doing quality inspection for your technique, maybe this will lead to improper diagnosis. If you don't do proper localization, this will lead to no benefit from just describing your lesion right. So what's the lexicon? Lexicon is a dictionary we use in the mammogram or writing our reports, breast imaging. These are standardized terminology that leads to writing a clear and direct report for our modalities. So each imaging modality has its own lexicon. There is a mammography lexicon, there is ultrasound lexicon, there is MRI lexicon. So for the mammography, we have to describe the breast composition, either fatty up to the glandular. This is go from A to D. Then we have, if you found a mass, you have to describe it in view of the shape, the margin, and the density. So if the lesion has a speculation, this is a worrisome finding. If it is fat density, this is something go with peninicity. So it's very important to do this well. If you do this well, you will reach the diagnosis appropriately. Then if you go to the asymmetrical density, you should place both breasts in front of each other and compare, because right and left breasts are mirror image to each other. So when you compare, you have to detect any asymmetry and detect if it is found in single view, if it is focal asymmetry, global asymmetry, or developing asymmetry. And actually, developing asymmetry is the most suspicious one. And to do it, we have to compare it with the previous images. If the patient have done previous examination on the previous years, we have to compare. If the asymmetry grow in size, there is worrisome. Then we go for the architecture distortion, where we find no mass, but just a distortion of the parenchyma. And also distortion can be associated with mass or microcalcifications. So when we go for the calcification, I love to use this mammogram systematic approach. We have to first learn how to detect those calcification, and this can be done through the magnification additional views we added during our inspection. Then we have to do assessment for the morphology and distribution. And if there are previous examinations, we have to make the comparison to check for the stability. When going through the calcifications, we have to be minded with the benign forms of microcalcifications, because this leads to just PAARS 2, and we will discuss this later. And you have to be full-minded with the suspicious forms or morphology of the microcalcifications, including the amorphous type, coarse, heterogeneous, fine pleomorphic, linear, and branching, because those are the suspicious morphology. So you have to be familiar with their shape. When coming to distribution, we go from the diffuse, which most likely benign, to the segmental or linear, which is suspicious. So when you describe the microcalcification, you have to mention its morphology and its distribution. So any associated features can help for proper diagnosis, like pathological adenopathy, skin thickening, nipple retraction. This makes the diagnosis of cancer more confident. So you have to learn to search for the associated features. The ultrasound lexicon is more or less the same as the mammography lexicon, with some differences. Mainly on the ultrasound, in describing a mass, we have to go for the orientation, echo pattern, and posterior features, because this makes the difference between a benign and a malignant. The next key skill is very important. If I have the patient and I make a good description, shall I tell the patient to go home? Or go home and come for follow-up, or shall I scream for help? I need a biopsy for this lesion. So any mammogram patch have to be categorized into either a benign or a malignant lesion. So for a mass which has a circumscribed margin, fat containing, or a single view asymmetry, or a global asymmetry, or benign morphology distribution of the microcalcification, this most likely we will tell the patient to go home, or in some instance go home and come for follow-up. While if I find irregular microlobulated mass with speculations or asymmetrical density, which is increasing in size in comparison to previous studies, or I find associated architecture distortion or suspicious forms of microcalcification either on the morphology or distribution, then I shall send this patient to biopsy. And ultrasound, the same applies. If a lesion is well circumscribed, hyperechoic or anechoic, or there is not deeper but wider lesion, this goes for benignicity. While if I find the speculations or microlobulations, posterior shadowing, duct extension, this makes me more suspicious towards malignant lesions. So the final destination, or the pre-final destination and the diagnosis, the categorization of the ACR by RADS, which we are all familiar. But to reach this key, you have to have the previous keys with you. The ACR by RADS classification, this is a standardized protocol to standardize our language between clinicians and between radiologists. So if I go with category 0, this means that this lesion needs just additional imaging. I cannot reach a final diagnosis. Or this, I need comparison with the previous images. While category 1 and 2 and 3, those are the benign lesions, which I can tell the patient to come just for routine screening or short-term interval follow-up. While those categories are suspicious, so we need to do a biopsy or surgical resection. Okay. The reporting, we have to make a well-structured report. So the mammography report should include the indication for examination, breast composition, and the clear description of the important findings. And then we have to do comparison with previous examination, give the BI-RADS assessment category, and recommend the management. The same applies for the ultrasound report. Our last but not least important key is the radiologist-patient relationship. Actually, many of us can do this art of radiologist-patient relationship accurately, but not many of us teach this to the young generation. This is very much needed because anxiety is the main challenge you will face with your patient. And to take care of this, you have to give attention, communication, and assurance for your patient. Many are worried about artificial intelligence role in the life of radiologists, but this can give us more time to enhance our emotional intelligence in treating and dealing with our patients. Researchers done at the University of Zurich found that using humor during routine breast cancer screening improved the relationship between the doctor and the patient because radiologist is considered empathic. So you have to keep in mind building a long, healthy relationship with your patient that encourage future screening and create a memory inside your patient that will last forever. And finally, calm the anxiety of your patient. Listen to your patient thoroughly because this will make you know better and diagnose better. In this patient, there was inverted nipples, which she said it was congenital. And on asking her, she is following up a lesion para-areolar. She mentioned this for follow-up. So finally, keep yourself updating and keep the 8 key skills with you. I am honored to be the representative of the Egyptian Society of Breast Imaging and Manal Classroom. You just can follow up on Facebook to be updated with the coming year radiology education events. Thank you.
Thank you, Dr. Manal. And now we are